number one of the main challenges is obviously for our patients with surgically unresectable disease. We have to continue to find new treatment options for our patient population so we can assist them as best as possible with good quality of life, but still improving their overall survival. And, I think in the United States, we do not do a good job in regards to enrollment to clinical trials relative to other countries. I think right now we definitely still need some new interesting agents in development. There's, we have a fair number of drugs, but right now we are limited because some of the newer drugs that have been approved are solely based upon a particular molecular marker. So, for instance, encorafenib for BRAF mutant V600E tumor types. We have tucatinib for our HER2 3+ or 2+ FISH positive patients, which is 4% of the patient population. You have immune checkpoint inhibitors, which are a smaller number, right? Even smaller in the metastatic setting. They represent less than 5% of our patient population. NTRK is less than 1% of our patient population. So we're narrowing down the pool further, but yet we still have patients that don't have any of those particular molecular alterations, and so they need a more generalized approach. Fruquintinib is an oral agent. It's very selective for VEGF receptors 1, 2, and 3. You are correct. It was already approved in China to be utilized. However, that was only conducted in China. And in China, as well as other countries, their practice pattern in regards to the use of continuation of bevacizumab from frontline through second-line therapy in combination with chemotherapy is not required. It's not required here, but it's heavily supported. And so our practice patterns are a bit different. And so the purpose of FRESCO-2 was to basically try to evaluate this new drug outside of China in a patient population that's had more exposure to anti-VEGF therapy in the front line and the second line setting. And that's what this is. It's a very selective oral agent specific to VEGF receptors 1, 2, and 3. And to just contrast that, bevacizumab is what most people think of in regards to colorectal cancer, and that specifically binds VEGF-A. So it's just a different type of, it's the same pathway, but different receptor that it's binding. So FRESCO-2 was a large international trial that we conducted largely in Europe and the United States, as well as with some of our colleagues in Japan. And basically, it was a 2-to-1 randomization in patients who had received prior therapy. It allowed patients to have standard chemotherapy. That was a requirement, but also the consideration of the fact that patients were allowed to receive prior TAS-102 and or prior regorafenib. And the primary endpoint was overall survival. It was a 2-to-1 randomization. And basically, we were able to fulfill the primary endpoint. I should mention, sorry, it was a 2-to-1 randomization in comparison to placebo. And that was the recommendation at that time because there is really no standard of care in the refractory setting. Obviously, clearly it was an unmet need. This trial enrolled very quickly despite during the COVID epidemic. And so we were able to establish improvement in overall survival, as well as our secondary endpoint and an improvement in progression-free survival. And currently it is sitting at the FDA pending review for approval. very valid point. I know some people want to contrast it to Sunlight. Sunlight was a different phase 3 study that was specifically in the third line setting, and Sunlight is basically TAS-102 plus bevacizumab that was investigated for improvement in overall survival. Sunlight was a successful study. It was a positive study in the third line setting, but about a quarter of patients had never received prior bevacizumab because it was largely conducted overseas. It would not have rolled very quickly here in the United States. We were already utilizing TAS-102 plus bevacizumab. Here now, our trial, some people will criticize it. And once again, I want to mention it was conducted with my colleague, Arvind Dasari, who serves as the first author for this clinical trial. I'm I hate to say it, senior PI. He is the investigational PI, because that's my job at this point in my career, is to continue to mentor others, and it's been my pleasure to work with him for several years now. Going back to what you asked, so some people will criticize us because we said, well, it's a very heavily pretreated patient population. Yes, our median lines of prior therapy was 4 prior lines of therapy. The majority of patients, over 50%, had received prior Lonsurf, and over 40% had received both Lonsurf and regorafenib at some point. But I think it demonstrates that overall, this was a positive study in regards to overall survival. It is a single agent. It does not need to be combined with another agent, which I think is helpful for patients in this setting where they're trying to look at all their alternatives, and obviously quality of life is extremely important. And keep in mind, once again, the hazard ratio was 0.66 for overall survival, and so that is very favorable, meaning that there's a 34% improved likelihood of overall survival if the patients had received fruquintinib as a potential treatment option versus placebo. So in all the subgroups, there was overall there was a benefit for fruquintinib versus placebo, and I'm hoping that moving forward, we will see more development of this drug, just because it does have additional capabilities other than, I would hope, other than a single agent. It was tolerated very well. Class effect, for this class of drugs is basically hypertension, and that was seen in patients. Once again, that's treated with medications, same as you would for bevacizumab. And then some other side effects. Some patients did report some hand-foot syndrome, very similar to that seen with capecitabine. I think the number one thing is, please keep this in mind. We hope it's going to be approved by the FDA later on this fall/winter. We're very hopeful. And once again, it's another option for our patients. We want to continue to provide options for our patients. And I think it's important to demonstrate, I know it's hard for patients to participate in clinical trials, but these clinical trials do make a difference. And I just think that we need to continue to encourage people to participate in clinical trials moving forward. I should mention there was a negative clinical trial that was reported at GI ESMO, which is called the LEAP study of lenvatinib and pembrolizumab, and obviously that's disappointing, and hopefully by the time the publication comes out, we'll learn more information why this did not work in this setting for their patient population. And there are other ongoing studies at this time regarding obviously other investigational agents as well. So, we want patients to feel that there's still hope. We're not stopping. We're continuing to conduct other investigational agents, pursue other investigational agents, because we realize that, this is completely an unmet need for the majority of our patients.